Okay. Are we all ready to get going? Okay. So I think everyone knows about me now after after my cousin's speech earlier. But my name is Dominique. I'm clinically trained, so we have our standard training, but then we can take residencies afterwards and get a more comprehensive, in-depth, detailed training on clinical information. And right now I work predominantly with patients who are 65 and older. So I get to have a lot of conversations and kind of listen out for where the gaps are, the things that they know well, the things that they don't know well. And that has really, everything that you'll see here is really where I'm hearing the gaps coming from with the prescriptions that people are taking and the things they're reaching for over the counter. That they're not aware that they're grabbing things that do have their own risk and then can also interact with the prescriptions that they're taking. So we'll talk about what polypharmacy is in just a second. It might be a new term for you, but it's very simple. And then we'll also talk about what's happening in your body naturally as we're aging. And that changes the way medications impact our body and how our body also reacts and impacts the medications themselves. So even though we've been taking medications for 10, 15 years and we feel like it's fine, there's chemical changes that are happening that can now make us more sensitive to the medications that we've been taking for years. So we'll go through all of these things. And to simply define what polypharmacy is, it is taking 5 or more medications. This includes prescriptions, natural supplements, as well as over-the-counters. So if you're taking 5 or more, it's considered to be having a polypharmacy regimen. And this is something that we need to pay a lot of attention to because there are risks that go with adding on medications and whether that's what you're grabbing over the counter or even supplements that you're taking that are natural, right? Even natural supplements have things we need to be considering as well. And so pharmacists, we're constantly working with doctors because we are helping them understand what still needs to be there, what doesn't need to be there anymore, what's appropriate, what's not appropriate. And the prescriber's dilemma is differentiating between many medications and too many medications. So you can be on 15 medications and it may be appropriate for you. It may be the benefit is outweighing the risk. And that's what we use to determine whether something is appropriate. If the benefit of being on it outweighs the risk of the potential side effect. But if the risk of the side effect outweighs the benefit, then it's inappropriate. And so that's how we're gauging how to keep things on and what to take off. So there's about 20% of folks who are taking 5 or more medications. 10 or more. 20% of polypharmacy is including those who are taking 10 or more medications. And about 58% of those who are taking just 5 or more, we consider them to be potentially inappropriate. We estimate them to be potentially inappropriate, and we call it PIMS, potentially inappropriate medications. When we are now crossing into the threshold of 7 or more medications, our risk of side effects actually can go past 80%. And when each medication, each new thing that we add on, that risk increases 7 to 10%. So this is why it's very important for us to understand and have what we're taking and that doctors are regularly checking up on our regimen and making sure that it's still appropriate. The risk that we're looking for when we're reviewing your medication list, we're looking at the risk of hospitalizations based on what you have and how they can interact together. The risk of falls and fractures, the risk of memory loss and confusion, the risk of heart injury, kidney injury, liver injury, abnormal bleeding, blood thinning, bruising that's a little too abnormal, and then clotting on the flip side, and then also stomach ulcers. All the things that I'm showing you, we're going to go into which over-the-counters and which prescriptions can actually lead to these and compound these risks. So as I mentioned, things that may have worked well with us 20 years ago may not be the case anymore because we may feel fine, but our body is changing. The chemical changes are occurring, and that is going to start influencing the way you respond to medications. Uh-oh. Do we have the images? Okay. Is this the PowerPoint? Is this the PowerPoint? I had some more images on here.
It's the Canva.
Okay. All right. Well, we can keep going. So body composition changes that are occurring 65, once you hit 65 and continue to age, is there's less muscle tissue. And this is important because there are a lot of medications that depend on a certain amount of muscle being present because they go into the muscles, or sometimes on the flip side, we don't want them to go into the muscles. We want them to stay and circulating in your blood longer. And there's also less water, body water, and that also is important when we're looking at the chemistry of certain medications. And then body fat increases, and this can also sway the way that medications are working, where they're going and where they're staying in the body. And fat medications that are more drawn to fat, or more fatty tissue or fatty deposits, they can now stay in the body longer than what they used once to, which means it increases the risk of side effects. The skin over time becomes thinner and drier, and there's also underneath the skin there's less fat that's present. And there are medications that are the topicals and patches, they are relying on fat deposits to be underneath there so that they can absorb through the fat. They're relying on high blood supply and extreme good blood flow. And if we have decreased blood supply, decreased blood flow, that also means that drugs may not get absorbed through the skin as well, the ones that we apply topically. What this means is that the drug effect can be weaker, and then on some medications, it actually can be stronger. So these are things we need to even consider with topicals. The brain changes significantly. So we have chemical messengers in our brain like serotonin, dopamine, and acetylcholine. These chemical messengers are responsible for our mood, our memory, and our movement as well. Tremors are a result of acetylcholine being off balance, and our memory and our ability to, and where a lot of our antidepressants are changing the dopamine and the serotonin levels in our brain. So not only do we have a decrease of these in general, but also the signals that they rely on aren't as fast. They're just not, they're not firing as fast. And also blood flow to the brain may also decrease. So we will see increased sensitivity to certain medications that are relying on the brain to have vast blood flow, increased sensitivity that is affecting the chemical messengers in your brain. And we may need to lower the drug doses to make sure that we're not risking confusion, drowsiness, dizziness, or the risk of falls, feeling unsteady on your feet because now your movement is off. The stomach is also changing as well. So over time, the acid levels in our stomach is decreasing. The acid is important because it helps with immune function. It helps keep a good balance of good bacteria versus bad bacteria. And if that environment is changing, that increases our risk for infections. But that also increases the way that medications that rely on stomach acid to get absorbed well, it's going to decrease how well they go through the stomach and then go and get absorbed into your blood. Things like iron, thyroid medications like levothyroxine and calcium, they're relying on you to have a certain amount of acid in your stomach. So as that's changing, these medications can be a little harder to get absorbed the way they once were. The blood flow also to the stomach and the intestines slows down, and so that can mean you're digesting things more slowly. It takes longer to break down and process and for medications to get absorbed. So this can mean that medications can take longer to start working, or the levels that we're looking for aren't where we need them to be because they're not getting into your blood the way that we need them to get into your blood. We have to then think about adjusting medications. We might have to increase the doses, or we might have to tell you to maybe fall back on some of the over-the-counters that you're taking, like Prilosec, omeprazole, Pepcid, Tums, the things that also influence the acid levels in your stomach. And then the liver. This is changing because there's the theme is that there's decreased blood flow that's occurring through most of the organs, right? So the size of the liver will decrease, the blood flow will decrease, and then we have enzymes that are in our liver that are responsible for breaking down the medications that we use. And those enzymes can become less efficient over time, or they may not be as present as they once were. So now we don't have the metabolism that was happening that we rely on for safe processing of medications. So we might need to adjust again. We might need to decrease medications because they're staying in the body longer than what they were intended to. Or we might have to, instead of taking it every 4 hours, we take it every 6 hours, every 8 hours, and space it out a little bit more. And then we have to be careful about what else we're doing that stresses our liver. So alcohol and Tylenol also can put stress on the liver as well and be a compounding issue for the medications, the prescriptions you're taking that need your liver to be processing at its optimum. And then the last organ I'll touch on is the kidneys. So the kidneys are also decreasing in size and blood flow as well. The kidneys is what's filtering all the waste out through urine. And so there's medications that are going to be being processed out, broken down by the liver, and then excreted or wasted out through the urine. And this is happening slower. And the body now will start to hold on to drugs a lot longer, waste or toxins a lot longer than it's supposed to, which can increase the risk of side effects. Again, we might need to decrease the dose or space out how long we're taking them, since we know the body takes longer now to get rid of it. Things that stress the kidneys are dehydration. That will cause a kidney, that can actually cause a kidney injury. Large doses of ibuprofen, and we'll talk about that shortly. And then other medications that your doctor may have you on that really rely on the kidney to function. Oh man, my visuals aren't coming up, but okay, it's okay. So we're going to talk about over-the-counters. Need any additional help thinning the blood, because then if we fall, if we cut ourselves, then the body may not be able to stop bleeding. Heart disease. So we have a lot of evidence that shows when we take these medications at high doses every day, that it can actually increase our risk of heart attacks. So if we have heart disease already, we don't want to be relying on these. Kidney disease. As I mentioned, the kidneys are automatically, they are slowing down over time. What these can do is they can actually cause harm to the kidney. They can cause an immediate injury that can result in having to go to the hospital, especially if you are dehydrated in taking these medications, or if you're taking other medications that rely on the kidney to break down. They also can cause stomach ulcers. So if you have a history with stomach ulcers, or if you have general irritation of the stomach, this is probably going to work against you. What these medications do is they actually will start breaking down the lining of your stomach, and that we have our stomach lining there to protect us against this from happening. When we take medications, they shouldn't be causing ulcers in our stomach. But
they always say eat food before
eat food, yes. It helps coat the stomach so that it's providing a barrier and not letting that drug to just sit and start deteriorating the stomach lining. Now, again, we're not worried about this if you're using it occasionally, but for those, and I see it almost every day, people taking them on a daily basis, around the clock, or at high doses, this really increases your risk. Other herbals that we use that do also cause blood thinning are fish oil, John's worts, and saw palmetto. Saw palmetto usually is males that will, this helps stabilize testosterone levels. Fish oil is used, we use that for heart health, for brain health, cholesterol, and that's fine. The blood thinning effect usually is when we're like at 3,000 milligrams a day. So if you're taking 1,000, 2,000, you should be fine. But St. John wort is what folks are using to help with memory naturally. But this can absolutely interact with the over-the-counters. And St. John wort also interacts with the regular blood thinners and heart disease medications. A lot of medications that we're using to treat heart disease.
What's the deal with saw palmetto? Because I resemble that remark.
I'm sorry?
What's the deal with saw palmetto?
It can interact with a lot of prescriptions.
Like what?
Well, we have,
For instance?
the medications that we're using to treat with depression, anxiety, medications that are being processed through the liver.
Okay.
I can,
Yeah, well, we'll talk offline.
okay. So this is what we're concerned about: stomach ulcers, blood thinning effects, heart attacks, and kidney injury. We're thinking about all of these things when we're using it at high doses and on a regular basis. So to decrease your risk, there's things that we can do. You can always ask your doctor or pharmacist, hey, I'm on these medications. Is it okay for me to take this for headaches, aches and pains, osteoarthritis? Take it with food on the stomach. You never want to take it on an empty stomach. And stay hydrated if you're taking this, because you can hurt your kidney. If you can, I know not every time we can avoid taking it daily, but I'm just giving you the if you can, right? If you can avoid taking it daily, avoid taking the larger doses, and please don't take over the maximum dose. On the back, it will tell you how much you can take of that particular one, and please make sure you're staying within those grounds. Diclofenac is also known as Voltaren, over the counter, is the topical form of ibuprofen and Aleve. So you can apply it to wherever you're having the pain. So this is good for if you have a particular body or a couple joints where they're prone to be more achy. You can apply it locally, and there's only about 6% that gets absorbed, so very low absorption. So it's a nice get around for when you need that inflammation power, but you're on these medications and you don't want to interact with the things that you're taking by mouth. This is another option for inflammation. It's not as, we know it's not as good as ibuprofen for inflammation, but some people do still find relief from Tylenol. So if you have more of a widespread effect where you don't want to apply Voltaren all over your body, several times a day, that can be an option. And you can also use these together. You can take Tylenol and then you can supplement with the Voltaren on the joints that you need. Okay, this is a big one. Proton pump inhibitors is what they're called, but you may know them more as Prilosec, omeprazole, Nexium, esomeprazole, and those are over the counter. And then we have pantoprazole, which is prescription. And these are being used to change the acid levels in our stomach. So we're using this to treat symptoms of GERD, acid reflux, but also we use them to treat stomach ulcers or prevent stomach ulcers. So sometimes you're on certain medications that increase your risk of stomach ulcers. So it's actually appropriate to put one of these on board to protect your stomach from harm, because it will neutralize the stomach acid that you have, which creates a calmer environment. These interact with a lot of prescriptions. They interact with levothyroxine, clopidogrel, Plavix, certain antibiotics can interact with them as well, calcium, iron. So the trick is that you don't have to avoid them at all, but you do need to know that sometimes we need to space them out by 4 hours or 6 hours from these medications to make sure that the highest window that it's neutralizing the acid doesn't interact with the medications that rely on your stomach acid to be absorbed. Plavix, in particular, if you are on Plavix and you need to be on one of these medications, you should only be on pantoprazole. These can decrease how well Plavix works. It will stop and decrease the way it's supposed to be preventing clots and heart attacks and strokes, and can basically almost void the effect that Plavix is trying to have. Pantoprazole has the least amount of risk out of these two. So whenever I see that, that's a big flag. I'm immediately messaging the doctor and telling them we have to switch the one that they're on. Another thing is that they decrease bone mass density over time. There's data to show that overall it increases your risk of bone fractures by 33% when you're taking these on a daily basis for 6 months or longer. It weakens the immune system, again, because it's changing your acid levels, and our acid does have an immune function, but also because that change in acid changes the way your body takes up nutrients and also from your vitamins. So you'll see B12 deficiencies, magnesium deficiencies, and as well as calcium, which is contributing to the bone fracture risk because our bones rely on good calcium and vitamin D levels.
You say this is proton pump inhibitor.
Yes.
Is Protonix a proton pump?
Yes. Protonix is.
Which category do you put that in?
Protonix is pantoprazole.
Okay,
Yes.
thank you.
I'm sorry, was that one? Again, couldn't read that name.
Pantoprazole.
Which one?
Pantoprazole.
So Prilosec and Nexium, which is omeprazole and esomeprazole, you can buy over the counter. Pantoprazole is a prescription. But just like everything, there are times where it's more beneficial to have these on board, and we would rather you be on this because the risk is more concerning. The risk of not being on it is more concerning, I should say. So if you have a history of stomach ulcers and we can't fully track what caused it, and we can't remove the cause because we didn't identify what it was, then it's best to keep it on because it's going to help prevent against recurrent stomach ulcers. If you have a diagnosis of Barrett's esophagus, meaning that you have erosion of the esophagus because the stomach acid has been so high, it's actually been eroding the lining of your stomach up to your esophagus, then we need to have these proton pump inhibitors on board. If you're taking 2 or more blood thinners, we need to have this on board because it's protecting against stomach ulcers. If you need to use those NSAIDs that I talked about, the ibuprofens, the Aleve, if you have to use them chronically, then we need to make sure that something is on board to protect your stomach. And also, if the symptoms of the acid reflux are so severe that you're having difficult or painful swallowing, then we probably need to have these on board to help soothe the acid that is causing so much irritation. So if you fall into this category, you just want to make sure that you're getting your labs checked regularly, that they're looking at your vitamin D labs, your vitamin B, your magnesium, to make sure that your nutrients are getting absorbed and they're where they need to be. You want to make sure that you're getting routine osteoporosis screening for women who are 50 and older and men who are 70 and older. And then, depending on the levels, we may need to just add some additional supplementation, vitamin D, calcium, B12, and magnesium. When it's not appropriate is when you're having some acid reflux here and there, but you're going for these all the time. These are your go-to. And if you're still taking them and you haven't had symptoms in months, you don't even know if this is still an issue for you anymore, but it's just kind of like a part of your regular routine now. We might need to see if we can back off and go down, we call it de-escalating or de-prescribing to something with less risk. If you're having mild to moderate symptoms, you can probably try something else. I'll show that in the next slide. If you have symptoms less than 3 times a week, you probably don't need to be in this taking these medications routinely. And also if your acid is being triggered by a preventable cause. So if you know that hot sauce that you're putting on your food all the time is causing the acid reflux, and we have medications that we need to make sure that are working, prescriptions that we don't want to mess up the way they're supposed to function, we might need to address what we're doing that's causing the symptoms, right? So if you're in the category of not appropriate, we want to wean down slowly. You do not just stop taking these if you've been taking them every day for months, because you'll get rebound acid reflux. It will shock the acid levels in your stomach and symptoms will come back worse. So we want to slowly decrease the dose, maybe go to every other day, every other 2 days, and address the root issue and use safer alternatives, which are antacids, which can be Tums or Mylanta. These are good for when you are having active symptoms and you need to relieve yourself fast. They can work within minutes and they can last up to 2 hours. But be careful because they do have calcium and magnesium. Calcium can cause constipation, magnesium can cause diarrhea. So we want to be mindful of that as well. And they can also interact with some medications as well. Pepsid or famotidine, this will block acid from being produced. So you can take this as a prevention. If you know, if you want to go to the cookout and eat what you want to eat and you know it's going to flare, you can take it 30 to 60 minutes, or if you know when you lay down, you might have symptoms, you could take it 30 to 60 minutes before bed and get ahead of it. And it can prevent, it can block that absorption for up to 12 hours.
Excuse me, let me ask about ondansetron. Does ondansetron fit into this area?
No, ondansetron, it doesn't fit into this area, no.
Oh, okay, but it does soothe the stomach.
Yes, ondansetron is helping with nausea symptoms. It's actually targeting some chemicals in the brain to help with not using the nausea issues. Antihistamines, this is the last drug category that we'll talk about, over the counters, but these have a very high risk of dizziness, confusion, memory loss, short term, but also long term if you're taking these on a daily basis to help go to sleep every night. If also drowsiness and residual drowsiness the next day, that can increase the risk of falls. They can cause you to be constipated. They can cause dry mouth, dehydration, dry eyes, and urinary retention, which means you're having trouble going to the bathroom. They dry you out, essentially. This is why we can use them for cold symptoms, because they help dry out the mucus, the runny nose, but they also will dry out our mouth, our eyes, make it harder for us to urinate. Allergy medications, Benadryl is a big one, but I want you to notice how Benadryl is being marketed for allergy and sleep, because it's so sedative that it can do both. So they're marketing allergy for just as allergy, 25 milligrams of diphenhydramine, which is Benadryl. And then here they have 50 in Unisom. I know you can't see that, but I'll show you. In Unisom, which is being advertised for sleep, they're putting 50 milligrams in it. But then down here, CVS is saying it's a sleep aid and also saying it's 25 milligrams, which is the same amount that the Benadryl allergy told you they have. So we have to be careful about these things because they're marketing them differently. But if it shows you that they're advertising to you for a sleep dosage and you're also grabbing it for allergy dosage, that's concerning. If you're getting in your car and you're driving somewhere, you need to do something where you need to focus or watch where you're stepping, and you essentially took a sleep aid, kind of, that's problematic. We don't want to keep doing that. We need to be mindful of what it actually can do. And then Tylenol PM, I have this here because a lot of people tell me that they take it to go to sleep, even if they don't have aches and pains, just because it says PM in it. But it has diphenhydramine, it's Benadryl. So now you're taking Benadryl and another medication, Tylenol, just to go to sleep. It does work, but we need to be mindful of the risk. And you can develop a tolerance over time. So 25 milligrams might have worked, and then all of a sudden now it's not working, and you have to keep going up and up and up to get the same effect. Yeah. Well, tolerance. And then the most sedative over the counter, that in general, but over the counter is doxylamine, which is advertised in Unisom, ZQuil, and then also regular CVS sleep aids. So see how Unisom is just marketing things? Sleep gels, sleep tabs, and we're just marketing things to get your attention, to get you to pick up. And you're picking up the most sedative antihistamine that we have.
Can I say something?
Yes.
If you're gonna take some ZQuil, you need to read the labels on the back because it will give you nightmares.
Well, yeah.
Nightmares.
Well, these antihistamines, they can increase the brain activity overnight and make vivid. Melatonin can do that too. That can also give vivid dreams as well. But so this is just the things I want you to be mindful of, and not to just trust the name that you're seeing on the packaging, but to understand what the actual ingredients are and how they work.
Makes me so glad I stopped that Benadryl.
Yeah. So safer alternatives. Melatonin is helpful if you have trouble falling asleep. It's not something that's going to help, keep you asleep. But melatonin is what our bodies naturally release once it starts getting dark outside. It's what God created in us to help get us to get tired when the sun is going down. So it helps put us to sleep. But it can cause next day grogginess. It can also cause headaches the next day, and it can cause vivid dreams. But everybody has their own response to it, like all medications. Again, tolerance can develop over time, but we don't really have a maximum dose for melatonin. And then I also like to recommend herbal tea blends, sleepy time tea, ingredients with chamomile, passion flower, valerian root. And if this isn't working, the over-the-counters aren't working, you can talk to the doctor about getting a prescription to go to sleep, where they're actually weighing what other prescriptions you're on and what's going to be the best option for a prescription to help go to sleep. If you've been taking Benadryl for allergies every day, there's safer alternatives for you too. Allegra or Claritin over here. These are the least sedating out of the options that we have. And I personally hear the best results from Allegra. When people say that the Zyrtec and the Claritin isn't cutting the symptoms, it's not doing it the way the Benadryl does, I hear good results about Allegra.
Very expensive.
Expensive? Yeah, it can be. Levocetirizine is a newer one that's been popping up called Zizal. And you can ask your insurance plans which ones they have of these, because a lot of times they'll cover them. Zizal is basically Zyrtec, but it's just built to last longer and be more effective. So you can look into these things and ask your insurance company what they cover on your formularies. And then, so these are the over-counters, but then there are lots of prescriptions. And if you can screen and see if you're taking any of these, but they have those antihistamine Benadryl-like side effects. So if we're taking antidepressants or medications for sleep, we need to be careful because that can create more confusion, that can create more grogginess. If we're having nausea, vomiting, or treating vertigo, we need to be careful. That's going to interact with a lot of medications in those categories. Sometimes we'll do prescriptions for itching or allergies, which can be hydroxyzine. Overactive bladder, urinary incontinence, oxybutynin. These things have a lot of side effects that cause dizziness, can dry you out, and can have symptoms that sometimes don't make it seem worth the relief. Medications that are used to treat tremors. This is also something that can interact, mood disorders, if we're treating irritable bowel syndrome, because these drugs are trying to stop diarrhea, so they're drying out the stomach. And so if you're taking something else that's drying you out too, it's just compounding. And then muscle relaxants like Flexeril, cyclobenzaprine, has a lot of these side effects as well. And if the doctor is treating you with opioids and benzos, I just want to put in a cautionary message to you, because we will reach out to them to tell them about this, how inappropriate it is, and we don't hear much response a lot of the times. But it is something to be weary of. So opioids are your medications like oxycodone, hydrocodone, codeine, which you can get in some of the over-the-counters, tramadol, benzodiazepines like alprazolam, or I'll say Xanax, Ativan, Valium, Klonopin. And so when we're taking them together, which I see often, we are intensifying their own individual effects, and we're just compounding them onto each other. They all work in the brain to do what they're supposed to do, and they have, individually, they have high risk of dizziness, falls, memory loss, drowsiness, confusion. Specifically opioids, we are worried about respiratory depression. Has anyone heard of that? Opioids, when taken too much, can tell your brain, they will signal your brain to tell your lungs to stop inhaling and exhaling. They will tell your lungs to stop breathing.
That's serious.
So when we take these Xanaxes, Ativans, and Valiums on top of that, it compounds that signaling. It's called respiratory depression because it is slowing down or stopping your lungs, your respiratory system.
So they're only issuing to take the two together, not individually?
There's high risk with both, but they're compounded when together. So, for example, 1/3 of opioid overdose deaths involve a benzodiazepine, which is very, very high. And there's a 10 times higher risk of having an overdose death when we're using these together versus just opioids alone. So this is a very, very, this should not be on longer for 2 to 4 weeks. Benzos in general, the Xanaxes, Ativans, Valiums are not supposed to be treating long-term anxiety. We're supposed to be using them to help bridge over to therapies. Like if your doctor is starting Zoloft to treat anxiety, it can take a couple weeks to actually get in your system and work. So the doctor may want to put you on Xanax to help control your symptoms in the meantime, but he or she is supposed to be taking it off eventually. It's not supposed to stay on. Sometimes we have to with seizures. We're trying to suppress seizures, and we tried all we can do. Like I said, there's always exceptions for everything, but I'm just giving you the average case scenario of what is typically not appropriate. Anything here? Okay. So the 4 things I just wanted to drive home today is that being on multiple medications increases your risk of side effects, but just because you're on multiple medications does not mean that it's not appropriate, right? It just means that we have to be a little bit more mindful of what we're taking and what we're grabbing, especially over the counter, because these over the counters, we call them OTC, over the counters, they have their own serious risk, and they can also interact with prescriptions. If you are buying it over the counter for the first time and you don't know much about it, just bring it up to the counter and ask. Especially if you're a patient there already at that pharmacy, and the pharmacist can pull up your meds really quickly and do a quick scan and see if it's appropriate for you. Or ask your doctor, call them up and say, hey, I'm thinking about taking this, is this okay? And then you want to make sure that your medication list is being routinely screened for safety and efficacy, and by efficacy we mean that it's actually working well for you. So whatever you're on, it should be safe as possible and actually working for you. Yes?
What's the difference between a pharmacist and a pharmacologist?
Pharmacologist has a PhD,
Okay.
so they go through a PhD program where they are defending a thesis. Some pharmacists do both, but they are not a doctorate of pharmacy. They have a doctorate in they have a doctorate in pharmacology, which is the study of the chemistry of medications.
Okay.
Yeah.
Thank you.
They can't work behind your counter. They're not legally licensed. Okay, that's all that.
Does anyone else have any questions? I want to thank you. This has been very,
Okay.
Seemed like I had something in every category.
Okay. Okay. Yes. We have a question up here too.
Yeah. I have a question.
Yes.
What is the view on things like ginger and turmeric and those kind of things that you take?
Yeah, so turmeric is a nice natural anti-inflammatory. That one I haven't seen too many. So we say things, when we say something is a significant risk, there's two ways that we view it in the medical world. It can be a risk based on the data, but then it may not be actually relative, like clinically, and that means when it's applied in real life. So taking the turmeric, for example, that also can have some slight blood thinning effect, but I haven't seen too many issues with people taking turmeric